Today I am presenting sentinel lymph node biopsy in T1, T2, N1 patient converted to node negative post NACT. So I am Dr. Sanjeet Kumar Agarwal, working as senior consultant in breast oncosurgery department of Tata Medical Center, Kolkata, India. So what population we are talking about? It's clinically and radiologically T1, T2 and N1 disease. So we all know T2 disease means when the tumor size is less than 5 centimeter. What is N1? N1 is ipsilateral mobile node. So it should be within level 1 and 2 or clinically node negative but USG suspicious node. So all nodes should be confirmed by biopsy or FNAC to be having metastasis from the breast tumor. And the post-NACT during clinical and radiological examination, we should see the complete nodal response both in clinical and radiological examination. Radiological examination means USG breast. We have looked upon our data and what we found that in C1N1 patient post chemotherapy, the nodal response was 46.6%. And we all know that many studies have summarized the nodal response. And in these 4 studies, the complete nodal response was in the tune of 50% in TNBC and around 60 to 70% in HER2 positive breast cancer. And in HR positive and HER2 negative, it is generally less than 30% or around 20%. So if we are thinking for de-escalation of axillary surgery, probably TNBC in HER2 positive group will be a better candidate than HR positive and HER2 negative breast cancer. We all know that we have 3 prospective validation trials where sentinel lymph node biopsy was done, followed by validation axillary dissection in post-NACT setting, where node positive patients have converted to N0. There are 3 studies. One is EcoSOJ study, second is Sentinel study, and third is SNFNSA study. And if you see, the false negative rate was more than 10% on all these 3 studies. In subgroup analysis, what we found that the FNR was less than 10% when dual dye was used in Sentinel and SNFNSA study. And when 3 or more sentinel lymph nodes were removed, FNR was less than 10%. Or when FNR was less than 10% when the clip node was removed. Clip node means the nodes were clipped before chemotherapy, and these all are the biopsy proven metastatic node. So to summarize these 3 prospective validation trial finding, overall FNR was greater than 10%. FNR was less than 10% in selected group of patients, mainly when dual dye was used or 3 or more sentinel lymph nodes were removed or clip node were removed. There was a meta-analysis published in 2018, and what we found that the false negative rate when dual dye was used and more than 3 sentinel lymph nodes were removed was 4% only. What is clip node? So we all know about the targeted axillary dissection. It means you clip the node before chemotherapy and after chemotherapy, do sentinel lymph node biopsy plus the clip node. That's known as removal of lymph node with history of metastasis. What is targeted axillary dissection? And this was a study which was published by MD Anderson group. And it was found that when you are doing targeted axillary dissection, FNR was 4.2% only with the clip node, and the clip node was not among the sentinel lymph node in 23% of the cases. So to summarize, false negative rate in this study with sentinel alone was 10.1%. But when targeted axillary dissection was done, it means sentinel plus clip node, the false negative rate was only 1.4%. To summarize overall, when the false negative rate was less than 10%, or how we can achieve false negative rate of less than 10% in post-NACT setting. So if you are doing sentinel alone, you should remove 3 or more sentinel lymph node and using dual dye. If you are removing only clip node, the false negative rate is in the tune of 7% as per the marriage study from the Netherlands. And the TAD had said that clip node plus sentinel has the false negative rate of 1.4%. So again, in the decreasing trend, clip node removal only 7%. With the dual dye and more than 3 or more sentinel lymph node removed, 4%. And with the targeted axillary dissection with a single center study was 1.4%. I want to highlight the sentinel lymph node biopsy in early breast cancer. What was the reported false negative rate? Was it less than 10% across all the studies? So the answer is no. So if you can see here, multiple studies have published the false negative rate, and it was more than 10% in Sentinella GWOM study, which was 16.7%. And it was close to 10% in majority of the study, 9.1% in Canavas et al. Study, and in B32 study, it was 9.8%. So what I want to highlight that even in sentinel lymph node biopsy in early breast cancer, the studies have quoted the false negative rate of 5 to 15%. Can we do sentinel alone, or shall we do targeted axillary dissection? So this is a very good study which was published recently by MSKCC. What they have done, they have clipped the node before chemotherapy and have done sentinel lymph node biopsy only. They have not done targeted axillary dissection. Total 269 patients, and greater than 3 sentinel lymph node was removed in 251 patients. So you can remove more than 3 sentinel lymph node in 93% of the patient as per this study. The interesting finding is when you are removing more than 3 sentinel lymph node, clip node was among the sentinel lymph node in 88% of the patient. So if you are removing more than 3 sentinel lymph node, chances of having clip node is 88%. The next group of the patient where more than 3 sentinel lymph node was removed, but node was positive. So axillary dissection was done. So the clip was retrieved in ALND specimen in 5% of the patient. The third group of the patient was where more than 3 sentinel lymph node were removed, but clip node was not present. So axillary dissection was not done. It's a very minority of the patient, 7% only. And as per this study, there was no axillary recurrence in 55 months of follow-up. What's the problem with the targeted axillary dissection? So we all know that for targeted axillary dissection, node to be clipped. It's a very vague, which node you need to clip, from which node you will do biopsy, and it's subjective. For identification of the clip node, especially in the developing country, you don't have the luxury of the radioactive and MAC seeds. And we all know that the wire localization of the clip node is very difficult, and it may be very cumbersome. The clip identification rate itself in a German multicentric study was 86.9% only. And we have seen the clip migration rate of 2 to 30% in different studies. It's a costly, and you need to do multiple additional procedures. So when I am comparing optimized sentinel, that's the dual dye and more than 3 sentinel lymph node versus targeted axillary dissection in post-NACT setting, clip identification reached 88% versus 86.9% in the two study. And the false negative rate was 4% versus 2%. So we really need to think, do we need to do targeted axillary dissection? And probably in the developing country where the availability of radioactive seed and max seed is an issue, we can really adopt optimized sentinel lymph node biopsy in the post-NACT setting. Do we have outcome data? Yes, we have outcome data. So first study was published by Milan. N1, N2 patient converted to N0, where sentinel was done, and in axillary recurrence, and 10-year axillary recurrence was only 1.8%. Second study, which was published recently by MSKSS group, T1 to T3 N1 disease, only one axillary recurrence in 40 months. The recent study, which was published in San Antonio Breast Cancer Congress, it was 1,600 patient study comparing the outcome of TAD and Sentinel. And 3-year axillary recurrence was same in these two groups. There was a meta-analysis recently published in the British Journal of Surgery, and the 5-year disease-free survival and overall survival with the sentinel in post-NACT was 86% and 93%, which is fairly acceptable. To conclude, mainly in TNBC in HER2-positive patient, in T1 to T2 N1 disease, you are giving chemotherapy, and if you are seeing a node-negative tumor, complete nodal response post all cycle of chemotherapy, we can use dual dye sentinel. You need to remove more than 3 sentinel lymph node. So it means that if you are removing less than 3 sentinel lymph node, then you need to do the axillary clearance in this group. SLNB is required when you are removing less than 3 sentinel and all are negative for metastasis. You may consider axillary RT with some of the retrospective study, but for saying it conclusively, we need to see the alliance trial result. SLNB positive for ITC and micromets. Yes, we may consider axillary RT. Again, there is no level 1 evidence. And SLN positive for macromets, we need to do the axillary lymph node dissection. Thank you.